Okay, we have some people joining right now.
Good afternoon, Prof. and Doctor.
Hi, good morning.
Morning there, afternoon here.
Oh, is it afternoon? It's Indonesia, isn't it?
Yes, correct.
Hi. If you can put in the chat, please, the information I requested while we're waiting for others. We're going to start in 3 minutes.
Yes, I will put that. And we will also send out like a formal survey after. But
Cameron, do you want to start off with the slide sharing in about 1 minute?
people are filtering in right now. Yeah, I'm just gonna keep it in this view so I can see the chat at the same time and everyone's face.
So it's exactly 5. I think we should start on time. Janet, Mary, Peter, Rena, Cameron, we should start on time so that we are punctual. Good morning, everybody from Calgary. It's a pleasure to start off with the Occupational Medicine Unfiltered Session 1. And myself, Avi, I'm in Calgary. It's 5 o'clock in the morning and it's a beautiful day. The sky is quite clear. I've got my co-host with me, Cameron Kayani. Cameron, I'll leave the floor for you to say hello.
Hi, how's it going, everyone? Pleasure to be here.
Perfect. Cameron is in San Francisco. It's 4 o'clock in the morning. This is one of, I hope, many sessions that we will have to discuss occupational medicine. The challenges we are facing as a specialty are quite important, and I think it's universal. It's not confined to any single country by itself. And I'm glad that I'm having individuals from the UK, I'm sure from Indonesia. And I think, Cameron, somebody is telling me that they're trying to log in but can't find the meeting ID and password.
Direct them to use the link that you posted.
Okay.
Did they try that? We've got about 19 people here.
Okay, perfect. So because we have minutes, it's going to be tight for us. Let's move to slide number 2. Cameron, welcome.
Yeah.
So this is the agenda. I thought of it as 90 minutes, and what we are doing is we're going to keep it to 90 minutes this time, hopefully, and we'll be able to cover a lot of things, focusing on what is principal at this moment. With that, let Cameron talk about the housekeeping issues.
Yeah, we didn't make it a webinar and we made it a regular discussion meeting because we wanted it to be an open discussion. And so with that, just need to ask that people be thoughtful about how long they speak or talking over other people. Just be mindful if your mic is on or off. If you have a comment, it can be a little bit longer too. That's okay. But make sure that everyone has time to speak. If you do want to make a comment, we ask that you, or ask a question, we ask that you raise your hand so we can keep things organized. We'd love to have your camera on, especially when you're speaking. This is being recorded. We would like to share small clips of people talking, particularly if someone's saying something impactful, a message we would want to amplify. That's why we ask that your cameras are on. We will move through the agenda. Any comments or questions, just put them in the comments.
Good.
And that brings us to 4:05. So that takes us right to framing the challenge. I see people are filing in. Hello, very exciting. Hi. Just put your information in the chat. Let's move now to framing the challenge.
Actually, if you can go back one slide, Cameron, I think it's very important for us to know which country, which city you're from, if you're employed or contractor, licensed or not. If you're a physician and nurse, please specify that, or occupational hygiene. Also, it's extremely important for us to know if you're the country that you are from, if you have specialized training in occupational medicine, and if actually the country that you're from has laws that requires, and not good to have, but actually requires by law to have an occupational environmental medicine specialist to evaluate high-risk jobs, because that's going to be very important for us going forward. Also, if you are an academic, if you work in industry, if you're working solely for Workers' Compensation Board or private insurance, if you can specify, that'll be great. If you have a account, the idea behind that is that we should have in between their sessions a discussion of what's actually we're doing meanwhile, so that we can actually carry on with the activities in between sessions so we don't forget and we remain. And I promise you, you're not going to get any political, religious, or other messages in that group. I'll moderate that, just keeping it focused on occupational environmental challenges. Perfect. So let's move on to the next slide. Let's talk about the challenge. Why did I think about occupational medicine unfiltered? I was asked to be a keynote speaker over the last 2 years for more than 20 conferences on occupational medicine. I found that conferences were happening one after the other. You would have a conference in one country and then another conference in another country a couple of days later, or you will have 2 conferences happening at the same time, and so on and so forth. But the question I've been struggling with since 1997, when I started as an OCMED specialist, was actually, okay, so what's happening in the field of occupational environmental medicine? Do people recognize the specialty? Do our colleagues know about our specialty? Do they understand the scope of our work? work and how different it is from other specialties, be it specialties like cardiology, radiology, gynecology. Because if you name any other medical specialty, call it family medicine, call it cardiology, call it whatever, people have a picture in their mind of what's actually happening. What does this person bring to the table? What are their scope of work, capabilities, abilities, and how can they be evaluated by individuals, patients, workers, or whatever? When you talk about occupational medicine, there is the general public, the employers especially, the unions and such. Many of them may not have an idea of how different and unique our specialty is. So the question then becomes, how useful are our conferences? Our conferences only patting ourselves in the back and telling ourselves, oh, we're doing good? Or is it just for networking? Or is it actually, do we have an impact on the society around us? Do we actually make an impact on changing some sort of idea? What do we bring to the table? And actually, are we asked to be on the table or not? And that has been a struggle, especially with 19. I figured out that only, I would say, large employers knew about the value of occupational environmental medicine, be it in meat processing industries or be it in oil and gas or nuclear technologies, but not the moms and pops. So that actually made me think, why don't I start something and ask my colleagues, how can we take our specialty, our scope of work to the global audience? How can we make our specialty accessible? And how do we bring about the difference by making sure that our graduates are finding jobs, there are good jobs, and that we're able to actually fill in the required posts for our specialty to make an impact on individuals. This is the idea behind Occupational Medicine Unfiltered. Having worked with the Royal College in Canada with my colleagues over the last 12 years, hopefully things are moving in the right direction in Canada. We see what's happening in the States by means of cutting of programs, residency programs. I'm also acutely aware of Europe, that where individuals actually are not having, residents are not maybe that interested in joining occupational medicine. If that's a fact or not, I'm not very sure. I want to open that for discussion, whether there are jobs for occupational medicine specialists in those areas. Not only that you want to put people through the residency programs and they give the exams, but actually they should be able to find jobs, the same as an orthopedic surgeon or and so on and so forth. And then what are the competing medical fields that are taking away a chunk of our job? And the most important question to all of us, are we meeting the societal need actually or not? Keeping me on track, I don't want to go over my time allocated for this because this is for all of us, not for Jalabi at all. I don't like my own voice. This is for all of us to come together and start something grassroots. Maybe at the end of the session today, we will have something. My objective is to have a sort of a letter, all of us signing it together and sending it to an agency that we realize is a global agency that can help us become aware of our needs. And so we can at least start a dialogue among our colleagues. Even if I don't make an impact today, maybe 5 years down the road, maybe 20 years down the road, we will have something happening. So that is, in a nutshell, what I wanted to bring with me. And Cameron, take us away to the next slide, if you wish.
Yeah, for sure. Next slide. We just discussed framing the challenge. And now, for the next around 10 minutes, a discussion around a reality check. Where are we? Where are we right now?
Yeah, so here we have about 15 minutes. We want to talk about which countries are your country mandating occupational medicine coverage for high-risk jobs. Are there a certified process, and are there occupational medicine specialty programs in your country? What are the strengths and gaps for that? And then also the workforce shortage data, anecdotes, and so on and so forth. So we'll leave the slide on, Cameron, just to guide us. We've got about 15 minutes, and if you can just raise your hand, Cameron can mute you. It's your floor. Peter, go ahead.
Hi everybody. It's getting late at night here in Tasmania. In Australia, there is no legal requirement for any employer to use occupational physicians. So we're often competing with general medical practitioners. The next point is the training of occupational physicians in Tasmania, or in Australia generally, is quite ad hoc. A doctor who's interested in becoming a specialist occupational physician, really they have to find their own suitable job, and then it's within the field of occupational medicine, they have to find a supervisor who's prepared to take them on, and they have to fund their training themselves. Because we're a non-hospital based specialty, we don't have the supports available to other doctors who are hospital trained, like all the other specialties. Even general medical practitioners have funded training, whereas whereas in occupational medicine we don't. In my state, Tasmania, we're running into a very severe crisis in workforce numbers. We're down to about 2 occupational physicians for the state when we should have 5 or 6 for 500,000 people in Tasmania. We've set up our own foundation of occupational medicine to lobby the government about the need for training occupational physicians. So that gives you a bit of a snapshot from here. Thank you.
Thanks, Peter. The story in Tasmania or Australia is very similar. We have a residency training of 4 years. We have only 3 residency programs that are not strongly funded. We have to compete against family physicians to fill in the gap. The family physician take the majority of the jobs. My question to everybody is, what about the armed forces in your country? Do they have occupational medicine specialists supporting them, or do they have general practitioners covering that area of occupational medicine? Janet, go ahead, please.
I'm talking about the UK here. They have occupational medicine specialists in the forces. They usually go through a specialist training program supported by the National School of Occupational Health, who I work for. We have 2 different routes into occupational medicine in the UK. One is a formal training route. All of them are funded by the organizations themselves. There's no government funding, if you like. And through the one route, which is the MOD has, that's a 4-year specialty training program where supervision is put in place and the national schools support that supervision. And then we have an informal route called the portfolio route. I can see my colleague Trunda is on the call and he has been through that route, so he may be able to explain that a little bit in more depth. But we are having a future workforce crisis at the rate of training because the number of training places is limited. For the non-specialty route, the number of supervisors is limited. So we also have a difficulty. We're moving into difficulty, I would say.
Anyone else from any other part of the world? I don't want to put you on the spot, Marina. What about Indonesia? Go ahead, please.
For Indonesia, currently occupational medicine is on the incline state. People are start to notice, especially after COVID, where they see that companies who have occupational medicine specialists in place can continue their productivity. And we also have this mandatory government regulation from our oil and gas regulator, which stated that for zero tolerance for mistake industries like oil and gas, they have to have this occupational medicine physician in place. So for the oil and gas company in private sector or the oil and gas company in public sector, they need to have this occupational medicine specialist in place. So basically in Indonesia, we are currently facing increasing interest in occupational medicine residents. Unfortunately, we only have 1 center in University of Indonesia.
So 1 center for training in Indonesia for occupational medicine. How many centers do you have for orthopedics?
For orthopedics, we have more than 10 centers. For OBGYN, we have more than 10 centers. But for occupational medicine, we only have 1. Even for family medicine, which is relatively new in Indonesia, we already have like 3 centers. We left behind for the centers, but for the quality, we are sure we are in the right track, Prof.
Perfect. Thank you. Anyone else in any other part of the world, please? Martin, go ahead.
Martin, go ahead. You can mute yourself.
Can you hear me?
Yes,
Yes,
we
sir.
can.
Can you
Thank you.
hear me now? Thank you. My name is Martin Popovic. I'm from Belgrade, Serbia. I'm an occupational medicine specialist and an assistant professor in occupational medicine here in Serbia. Here we have everything formally looks great. We have a formal undergraduate and postgraduate education. We have an occupational medicine specialty lasting for 4 years. We have approximately 3 or 4 centers in Serbia. We are 6.6 million people country. And we have an occupational health and safety law. I'm currently employed in a military medical academy. We have occupational medicine in the military. We have a little, let's say, a challenge in military settings because in military settings you have practically 2 types of professionals nowadays. We have civilians and military people. We have high-risk occupations treated through civilian laws, but we also have the high-risk occupations that are treated through the military laws. Sometimes those jobs are not really the same and they do not go through the same regulations. So it's a challenge in the military settings. But in the civilian settings, the biggest issue is that we are under-recognized. Formally, we are recognized, but in practice, we are doing the ability assessments. Most of our jobs are fit for work assessments or driving assessments, armor assessments if you are able to wear arms or to have arms in the civilian or military sector. So most of our work is fitness for work, and our current health and safety law practically limited our role in the risk assessment procedures, in other other preventive actions. Currently, we are really understaffed, so we have a low number of occupational medicine specialists in our country because people are not interested into going into that specialization because they usually do not see the point of their actions, because those preventive actions that we can really do and help are not recognized by the companies as very important. And most of our work is done by safety professionals, safety at work professionals. We have a separate education for people who are into safety at work. Most of our jobs is done by them, and we are not involved in the preventive actions in the workplace mostly.
Thank you very much, Martin. That's a beautiful snapshot of what's happening in your country. I think the park away theme of what you've said to me was our outcome measures are not sexy. They're not very exciting. They're not very, because they are so many, like nobody wants to think about how many cancers you prevent or how many people were not shot dead because they were not fit to carry the weaponry. But it's far more important if somebody falls down and dies. So that's a takeaway that I've been seeing since, God, and I was only 1 year old back in 1992 onwards. And so the outcome measures that we have are not very exciting. For whatever reason, they are not seen as a return on investment. And so we need to work on that. So we're going to park this for next meeting. Thank you so much. Rosa, you wrote something and I wanted you to share that with us. Rosa sorry if I mispronounced your name. If you would like to tell us that verbally, please.
Thank you so much for organizing this. Yes, I'm Rosa. I'm an occupational health physician. I'm originally from Peru. When I decided to do occupational medicine, there was no training program in my country. It was in 2005. So I went to Spain, to Barcelona, and I did the 4-year training program there in Spain. And I worked there for 10 years. In Spain, the training program is very good, very comprehensive. The good thing about Spain is that there are loads of audits that they go to, inspectors that go to the companies. In Spain, it's very similar to France. It's mandatory, the health surveillance, and it's very well managed and developed there. I moved to Ireland after 10 years. Initially, when I arrived here, the specialty was not very well developed. Even companies were not aware of what was a risk assessment. They were sending me the job descriptions when I was asking for risk assessments. Fortunately, it has changed over the last years, and now that has grown. So I can compare Spain to Ireland. Both have a 4-year training program. In Ireland now, they also have the diploma of occupational medicine. There are few spaces for a training program. So if people GPs, they want to do occupational medicine, they can do that diploma of occupational medicine, and also they can become a license or become a MFOM, LFOM and MFOM. The task force of occupational health physician is low comparing to the demands. But one thing that it's lacking here, I think, in Ireland is that we are not recognized as consultants. All other specialties here, trained specialists, are recognized as consultants, and this is the only specialist that is not. That is a little bit of maybe for new doctors that want to become occupational health physician. On the other hand, because the Health and Safety Authority, they don't have enough inspectors to send to industries to do inspections, periodic health surveillance for noise, hand and vibration, or for example, immunizations, they're mandatory, but nobody followed that up. So that's why our specialty is not considered important, because nobody by the government is supervising those inspections. And I think that if the government here, the HSA, have more inspectors to do that job, I think our specialty will become a little bit more well recognized and more important. The value that we have is not seen yet. About things that we do here, we do health surveillance, pre-employment. We have private sector and public sector. It's very differentiated, and salary-wise and task-wise is completely different as well.
Can you explain, Rosa, what do you mean by consultant? Because this is not a word that we use here in North America. Just explain that to me, please. Thank you.
Yes, when you finish a medical school, if you do the specialty, you're called a trainee. When you finish a trainee, then you are a specialist. And when you become a specialist, then you get the degree of consultant. It's the higher level in a specialty. So you are called a consultant. It's important because when you have many years of experience to be considered as a consultant, when you work in the public sector as well, it's also salary. The salary goes, so you have a specialty salary of a trainee, specialty, and then consultant. During COVID, for example, the two specialties that were not recognized as consultant were public health and occupational health. And because during COVID, they noticed that public health specialists were so important, they got the degree of consultant, but not occupational health yet. So the faculty is trying to advocate for that, but I think it will be a long process. And that is making people not to choose this specialty because of the uncertainty of becoming a consultant.
If I understood you correctly, there is an impact on two things. Number one is seniority in the hierarchy of medical field. And the second one is the pay, which of course hurts your pocket if you're not a consultant in Ireland. Good stuff. Sarah Wilson wrote a couple of comments, and if I wanted her to say something, she has. We've got about 4 more minutes. Sarah, do you want to share your comments with us in the group?
Sorry, I've been listening. I'm a DRPH in public health with an occupational health and safety specialty. So it's a little different approach to this, but we do health and safety with high risk companies. So we do the diving, we do blasting and mining, we do that sort of assessments and risks. I'm curious, because we don't have that medical training, we get asked a lot, can we do the assessments? Can we do, what do we have to do when there's the incident? Can they go back to work after a dive injury? People don't even know about hyperbarics. I'm in Canada, Ontario, and we're still teaching about hyperbarics. What sort of training is there in med for these types of specialties like blast injuries, PFOs, in terms of getting back in the water? Do you get that sort of deep dive?
Yes, good. These are considered to be subspecialties in Canada and the Middle East. While I did my residency in Toronto, I went to the States and did hyperbaric medicine and so on and so forth. I also worked with NIOSH with regards to mining, blast, and so on and so forth. And then you learn on the job, but they give you the principles and the basics to conduct the surveillance, do the risk assessment, manage that risk, and then communicate that risk. So framework is the same. However, there are laws that govern the divers, the marine, and so on. So you have to get licensed. The extra badges, if you wish, on your chest, if you're in the military, that you have done this component. Now, I have not done hyperbaric for the last 25 years, but many of those, you do have to have recertification to join those. I hope I answered your question, Sarah. Good stuff. Now we are ready to move to the next slide, Cameron. So this is the meat today of our discussion. The question to what I'm hearing is from the last session, I'm just going to summarize what I heard. There are specialty trainings in the part of the world that we spoke about. There are issues with regards to return on investment for us as specialists. Return on investment is not very well known to the people around us because our outcome measures are not very visible and they're not very exciting like the safety folks. And we also have the issues with competing interests, competing specialties, taking parts of our job and taking away chunks, principal things that we need to do. So these are all, I guess this is universal. What I'm hearing is universal. Let's go back a slide. The slide that we're supposed to be at is core priority discussion. This is the meat of our meeting today. Here we go. So I guess the question I have for the group here is, in your opinion, should there be a law that mandates the ratio of occupational medicine specialist physicians and occupational health nurses per workers? To my understanding, Brazil does have that, but in countries like Canada, we don't have regulation that mandates high-risk jobs to have occupational medicine specialists. We don't even know what the numbers are, which are required when we compare our numbers for the Royal College. I was boggled. We were ranked quite low by the number of occupational medicine specialists per working population, although 51% of the population works. And the majority of individuals in the industrialized and non-industrialized countries end up working between the ages of 18 to 65, if not 75. Yet that's not seen. By the way, I'm not including homemakers, another group of workers that never get looked at, and they're not even considered in the occupational medicine exposures. Although many, and I don't want to sound as our friends down south call it S for socialist. I'm not a socialist, but I think about exposures. I think about risk assessment and so on. And then I also want to talk about the barriers and strategies to influence. And this is the last thing I want to talk about. The majority of this meeting now is about that. I want to hear your opinion that should there be a law that mandates that thou shall have this for this many workers, a nurse, occupational health nurse, that this many nurses will need to be able to report to a physician, and for this many workers and physicians have access to an occupational medicine consultant or a specialist, as we call them in North America. Tunde had your hand raised if you wish to share what you want.
Yes, Doctor. Thank you very much for convening this session. My name is Dr. I'm an accredited specialist in occupational medicine in the UK. And in my practice, I also practice in Africa, specifically Nigeria. And I've heard most of what our colleagues have said here with regards to regional practices. It's no different in Nigeria. When I wanted to go into occupational health practice, I had to take courses and trainings in foreign institutions because there was no training. But right now, there are some emerging institutions that are training people or doctors in that capacity. But coming down to what we're actually discussing here, laws mandate ratios of physicians to nurse per worker. It seems quite far-fetched to me because when we actually look at the whole medical discipline itself, there are shortages of no country actually has been able to fulfill the mandated number of doctors to to patient ratio. So if we now deep dive into occupational medical practices where capacity is low already, it will be quite challenging to have laws that would mandate a specific ratio between occupational physicians and work. And we have to actually be mindful of the fact that occupational physicians, okay, so do we just say that you employ a doctor? Because in Nigeria, the labor law says that a doctor, that is mandated for doctors to conduct fitness for work assessment for workers, but nobody actually says what the capacity of the doctors should be or should look like. So if we just throw it out that, okay, there should be a mandatory, who will be the occupational physicians? Is it just hiring doctors to do the job or encouraging scope creeps? In the UK, we see doctors in different specialties practicing occupational medicine independently, which should not be so. I don't see a GP with diploma in an O&G or other specialties practicing that specialty independently. But I only tend to see it in occupational medicine. If we are talking about having a ratio, we should actually deep dive into those key areas of us that needs to be considered before that, because truth is we don't have that capacity in terms of numbers. Before we can achieve, we need to improve capacity, and the public has to be educated that not all doctors that works in the factory or in an industry are occupational physicians. So that is my opinion with regards to this.
That's a very good, Tande, if you allow me to interject. So the issue is that occupational medicine as a specialty is more than fitness for work and return to work. That's a small part for what you do. The fact is that if you're not a specialist in any country, and I'm going to put somebody on the spot right now by asking them directly, you have to have an idea of occupational epidemiology, a cohort study. You need to be able to do a risk assessment, toxicology, occupational hygiene interpretation, biomechanics and ergonomics. You need to have an understanding of workplace exposure and occupational risk assessment, the economics of work and health. The biggest thing I found, honestly, if WHO, the World Health Organization, for those who don't know what WHO is, would have involved occupational medicine from the get-go, they wouldn't have shut down the world the way they did and had a serious impact on our mental health, but our abilities to make money, the individuals to go back to work. And although they came up with some few good ideas, I don't think the WHO level of intervention was what's good for the public. I don't think they understood the difference between public health and occupational medicine. It impacted the economics of work and health. I read a lot of economics. I'm not an economist. I don't have an MBA, but I'm just, from my days from oil and gas, I'm very much interested in what's in it for me, what's in it for society, what's in it for the other individuals around me by means of dollars. And truly, time is money. And so if that's the concept you're going to go with, I think that, in my opinion, as dentists do, we should have some course about not only risk assessment, but also cost benefit. Assessment should be part of occupational medicine training, in my opinion. We bring to the table systems thinking in disability management. The cases I see are usually at the end of the spectrum of severity. And if I would have been involved early on, maybe we could not have had that disability thing happening. And as the 20/80 rule, 20%, 80% rule is universal. So in the 20% who have difficulty going back to work, 80% may go back to work in the long term, 20% will never, and will become millions of dollars of cost to the city, region, or country. Just imagine the money drain if a disability is not managed well by a specialist. I see we have somebody from Tunisia, and I was hoping to hear our Tunisian colleague speak to us about their experience to make us truly universal and international in this conversation. Oscar, okay, we'll take Oscar first, and then we'll see if our colleague wants to. Oh, it's not possible. Okay, that's fine. Okay, Oscar, go ahead, please.
Hello, good morning to everyone. Thank you for letting us join this conversation. For context for the rest of the people, I have my work in Mexico. Currently, we face many of the challenges that many of you have already in the discussion. Getting to the topic about the question that you were asking about if there should be laws regarding this assignation of how many occupational medicine specialists or nurses per worker, I think the short answer is yes. I'm concerned about enforcement. And I don't know if many of your work developing other countries in which there is a lot of structure regarding agencies or governmental bodies that can enforce compliance with these laws. In Mexico, we are in a historic moment in which, due to the lack of many competent participants in the health and safety spectrum, there have been programs of self-compliance reports that industries can send to the authorities in good faith, trying to demonstrate they comply with safety and health regulations. This has provoked many people with not dedicated training, knowledge, and other forms of competencies have taken the roles of making decisions regarding, or maybe let's say invading, the dominion of occupational medicine tasks. In this case, my personal concern, at least in the space in which I work would be the enforcement of such laws. I think the main strategy that could be launched in parallel with an initiative regarding the mandatory assignation of resources could be derived from an socio-economic logic about why industries would want to have these let's say allocated resources in occupational medicine, right? In our country, especially in Mexico, I think the main challenge would be somewhat similar to what Tony mentioned earlier. There's currently a huge lack of general practitioners population for most of the community services. Occupational medicine is not the most popular specialty. It's also conditioned in part because the residency programs for this specialty in Mexico are very intimately linked with the governmental institution that takes care of workers' compensations. So in this case, a lot of the physicians that have training in occupational medicine in my country don't have that many, let's say, field experience. So this has developed in a sort of market with two factions of doctors, let's say, performing duties for governmental reasons, mainly associated with workers' compensations, and another set of practitioners, not necessarily certified, but that can develop the competencies that the industry demands. So it's not rare to see here in my country physicians who perform safety duties, who perform industrial hygiene duties, such as I currently do. And this has a good intention of protecting people, but maybe there are some people not taking the best technical decisions, right? So I think these kind of initiatives are very important. My concerns will be how to make the enforcement of such regulations and the socioeconomic logic behind that, so the industries would want to comply with this.
That's excellent. Thank you very much, Oscar.
Mary had a comment.
I'm just going to read off my screen because I've been typing some notes as we've been talking. I'm an occupational physician from New Zealand, but I work internationally. And I think to summarize what we've been saying, it's not just the number of occupational physicians, it's also the influence and the capacity within the workplace and within the health system. A lot of my industries have eliminated the occupational physician in-house to save money, and they've been outsourcing all the things that we used to do. There's a big shift in terms of prioritizing productivity rather than health protection. Work isn't what it used to be as well. There's now the gig economy, a lot of temporary employment and subcontracting and all of those things. So that weakens that employer's accountability to those workers. What Tunda was talking about is scope creep, where all those occupational physician tasks that we used to do are now being done by nurses, HR staff, safety people, or somebody else. As Tunda said, GPs with a diploma in something wouldn't ever do complex cesarean sections, but here they are doing all sorts of functions that we used to do. And so there's that loss of autonomy where that's a huge thing for us, because there's no legal obligation in many countries for anybody to have an occupational physician for anything. And so there's this perception that we're becoming more and more irrelevant, and a lot of employers underestimate occupational health needs, and especially the psychosocial stuff like all the stress and burnout and ergonomic issues. And we've also got that stigma of being the company doctor. So workers often mistrust us as well. It's really complex. And then this question about how many occupational physicians do you need per number of workers, we've also got to think that it might actually not be suitable for occupational physicians to be mandated by numbers, because they've got a fear of liability as well.
Thank you. These are some excellent points, and all the points that everybody raised were excellent. Thank you very much, everybody, to contribute. So here's my question back to the group here. As Mary was talking, I was thinking about two things. Number one is when you're not seen, you're not valued. Number two is when you don't work together, you're not seen as a group. And the bigger cohesiveness of a group is, the more the voice is going to be heard and the stronger is going to be our knock on the door. And that's one of the things that I'm using this unfiltered thing for us all as a global community, start to talk to each other and not to be in silos in Australia or New Zealand or Canada and so on and so forth, but actually start to talk about some things, because the challenges are very similar. I tell you this much, our headaches are the same, but I think the medication is also going to be the same. So we have identified the symptoms. I think we are heading to the diagnosis in the right path, and hopefully we'll be able to find as a group do a treatment for it. My question is to Mary, in your opinion, why is the job of an occupational medicine physician being watered down, is disappearing in your opinion, and given by and done in chunks by different individuals? Is it a legal issue? Is it an economical issue? Is it a legal economical issue? Or is it that employers are not walking the talk about workers being the most important asset?
I agree with all of the above, that there's a lot of lip service. In my experience, the best workplaces are usually the ones that have about 300 or 400 workers. Everybody knows pretty much everybody else, and they've all worked in different departments. So when you get to do any return to work, you can actually put them somewhere else and they've had experience in that area. If it's a bigger employer, then they get lost. And if it's a smaller employer, then they can't afford it and they don't really understand it. There's all sorts of reasons, and it's highly complex. And so this idea of how many occupational physicians do you need per how many workers, I did some notes before because there's some stuff about occupational health nurses. One of the rules is one occupational health nurse per 300 employees and an additional occupational health nurse for 750 after that. In Finland, there's some studies saying 1 in 720. And then occupational physicians, there's some studies that say about 1 in 1 part-time occupational physician per 1,000 employees, full-time occupational physician for 2,000 employees. In Finland, it's 1 in 640. It doesn't make sense to me because it's very blunt to say, oh, we just need a number. I think we need a model. 1,000 workers in a chemical factory are not the same as 1,000 workers in finance. Why are we just doing one number? I'm thinking about what you were saying before about the risk index. I was thinking about putting stuff in like the industry class, like manufacturing would be a number 5, whereas an office worker would be a number 1. Also the worker health complexity, like if you've got a lot of older workers or chronic conditions, the legal stuff, maybe some lag indicators like some LTIs or something like that. And then how much health prevention you're doing, like the health surveillance, match it to how many full-time equivalents you've got. And then I found the WO's workload indicators of staffing need and thought that would be a good start.
That's excellent, Mary. If you can share those references with us, that's helpful. I know we have somebody from Finland with us, so if you can talk to us about the Finnish experience, that would be great. Mikko?
Yeah, hi, thank you, everybody. I really loved your comments, Mary. I totally agree. What is the number of occupational physicians? I run a team of 80 occupational physicians myself, so I'm a supervisor to 80 physicians. Our focus has shifted mainly to primary care, to be honest. We're being critiqued quite heavily at the moment because we've lost the mission focus. Work is not so dangerous anymore in Finland. We've done a lot of work the past 50 years, so workplaces are generally quite safe. There's still so much to do. There's new toxins, new exposures, new things. Companies are losing sight of the risk assessments. They're interested in getting general primary care. So that's one of the things we struggle with. Our specialization is the first or second most popular in Finland due to the fact that this is highly employed. We work primarily in the private sector and the wages are quite competitive. That's one key issue already there. It's really nice to see this conversation going because even though we're developed the system quite far, we can still lose focus.
Perfect. Thank you so much. I was wondering if we have physicians from the Middle East, if they want to pitch in and tell us about their experience, because like one of the things coming out fast is the global, I'm going to say the word that the politicians don't want to hear, which is climate change. And the temperatures which are going very high with the ice being melted and so on. Who is going to train physicians to help in those hot areas or those cold areas turning now into a warm Mediterranean weather to be dealing with severe environmental changes? Do we have somebody who would willing to tell us about their experience and how will they be dealing with this?
Hello, everyone. This is Dr. Shay Malari. I'm speaking from the United Arab Emirates. The temperature is almost around 38 degrees here in Abu Dhabi. I'm going to briefly speak about the situation in many of the countries here in the region, where the main challenge when it comes to practicing occupational medicine is related to the lack of the legislative framework that mandates the presence of occupational medicine specialists. Many of the safety critical jobs are still taken care of by other specialists who will be sharing their advice and their understanding of the medical condition of that individual in the context of the organ system involved from their area of specialty. But if we look at that comprehensive evaluation that the occupational physician does in the context of the work environment with the understanding of the risk assessment, it does not really exist yet. The other caveat is related to lack of enforcement, and a lot of the currently available elements in the labor law, for example, in relation to occupational health services are not very prescribed and detailed. That makes it very general and not really helpful in the context of a structured occupational health service provision. Another area that I was thinking of is the implications of the input coming from other colleague specialists comes to concerns or questions related to workers' health from the work environment exposure perspective. I wonder if the same scenario can be looked at by our colleague, not that I'm trying to pinpoint a cardiologist, but I keep asking myself the question, if this question related to musculoskeletal injury comes to a cardiologist, is he going to answer the question the way I can see many specialists answering questions related to fitness to work? This takes me back to how much the medical school curriculum is looking at things related to occupational medicine. Do we have that embedded, providing the graduates or even GPs with the basic knowledge about things related to a fitness for work evaluation or exposure assessments in the work environment that can be used as a helpful approach for them to analyze questions in the context of occupational medicine practice? That's one thing that needs to be explored further and emphasized, because apparently in many medical curriculums it does not exist. If it is existing, it's very basic and, if I may choose the word, rudimentary. But to the point of climate change, I can see that recently there has been a lot of attention in the GCC countries about understanding the impact of climate change on work environments and how can work environments ensure that the workers remain safe. So that is another area where the leadership is having that better appetite to understand the role of occupational physicians and comprehensive occupational health and safety framework to be implemented and embedded within the system.
Thank you, Shema. It was excellent comments. A quick interjection here with regards to what you said about our colleagues who talk about fitness for work. I was recently reviewing a very complex case in which a cardiologist stated the individual can go back to work after 6 months of cardiac rehabilitation. The gentleman had cardiac neurosis and was unsafe to return to work, but he was able to return. I agree with you. When I do system analysis, there are three things which are missing. Number one is our scope of work needs to be clearly not only written, defined, but also communicated. Number two is others' specialties scope of work where it touches ours or interacts with ours also needs to be reviewed and maybe expanded into what are the things that they're able to talk about, what are the things that they do not need to talk about. I'll give you an example, and this is not a political, or this is not a, I want these meetings to be a comfort zone for all our specialists to talk about, but over the last few years I've been thinking about when every office does not have the fitness for work, both cognitively as well as physically, especially those decisions that are safety critical and safety sensitive, and those decision makers who are responsible for the lives of not hundreds or thousands, we're talking about millions, and their decisions can actually change political situations. Who's looking after them? Who's looking after their fitness for work to carry out decisions? I was really thinking about that in the last American, and of course everybody talks about the American elections everywhere in the world. We watch it like it's our own countries because the impacts are huge to all of us. But yeah, I think that one of the things that we need to work on as a group is three things. We are understanding where we are now. I heard from many of you where we want to be, and now the question is, for the rest of the meeting, we have about 15 minutes, how to get there. My challenge to all of us is right now, and if we can't do it today, let's start a WhatsApp group that we can put in something in thoughts going forward. But I'm really interested in a global unified thinking of how can we get to where we want to be. Because I think no matter how good your country is by means of occupational medicine, if number one, the leaders do not support us, then it's an issue. If there are not laws that are clear of our roles, then that's an issue. And what I heard from Mary was it's not the issue of numbers, it's the issue of capacity.
Oh, I wanted to say I agree. My philosophy is interdisciplinary collaboration. So I love all your talk about co-creation. I think that if we get into teams with not just physicians, but also psychologists and ergonomists and safety engineers, then we will restore our relevance and our visibility. And I also think that we need to do more with public health and join together with public health. And I think we should go bigger and talk about work and health ourselves as work and health specialists. So we could be the ones addressing mental health, the aging workforce, the digital stuff, or whatever. And again, the policy reforms.
Thank you. We do have a psychologist with us. If she wants to pitch in and tell us what occupational psychology can bring to the team, we have Warren. By the way, you have a lot of international experience and exposure. I would love to hear your ideas about what are the current challenges globally for our specialty and how can we actually address it in a way that puts us in a better situation in the next 5 years, 10 years, and 15 years from today.
Okay, that's interesting. I've been in medicine. I've been in occupational medicine since probably the early 80s. Before that, in the United States, we had company doctors, but nobody knew what an occupational medicine doctor was. When I first started my practice, the question I used to get, we have occupational therapy, but nobody knew what it was. The thing that drove occupational medicine to grow rapidly in that period was a bunch of OSHA regulation that said employers had to screen employees to make they could deal with certain hazards. We had new regulations with regard to truck drivers. We had an administration that was very aggressive about protecting workers. And it was a time when labor unions had strengthened the administration. As things have gone on, there's been a decrease in the threat to employers from regulatory agencies. There was also another emphasis back in the early 90s, and that was on employers saying that a work injury affected their bottom line. The cost of a work injury was really affecting profit. There was a great incentive to develop the field of occupational medicine. At this point, although we still have OSHA, we have EPA, a lot of the teeth have been pulled out. They've eliminated a lot of inspectors, and the penalties have gotten less. The other thing that's happened in the United States is that many physicians doing these jobs for employers that were held by doctors are now being done by nurse practitioners and physician assistants. There is a lot less demand for occupational medicine and an administrative situation where they're not willing to pay to train occupational medicine doctors. The funding in the United States has been threatened and withdrawn in many cases for all medical science, not just occupational medicine. Our field is then faced with future challenges. One is the fact that employees are going to be separated further from hazards through robotics and AI, and the number of jobs that are hazardous are going to decrease. In the United States now, we've got printers that can print houses instead of constructing them. We've got all kinds of jobs that are diminishing. So I see a lot of the direction that we could go in more in the consulting side, environmental and public health. I agree totally with a team approach, getting involved in public health, getting involved in things like global warming, the spread of different infectious agents into new areas. There are a lot of challenges for us to have, but the idea of going back to the way things were, which I think a lot of the older docs are nostalgic for, I think that's very difficult. I think we have to reinvent what we do. The other issue in developing countries that I've seen is the rising level of corruption, the interaction of foreign companies with local governments that leave out the worker safety part of it. In order for the local government to appease the foreign investor, they have to look the other way as far as employees. In many countries, the cost of injuring a worker is far less than the cost of anything else. Give them 5,000 or 10,000. They don't realize that worker who was working on the road and got hurt is not only his life, but also the people back in his village that now all don't have anybody to make the tuition and send the kids to school, can't buy food for the grandmother, can't buy anything. And he or she is now a liability. So we've got some big challenges. I'm concerned about trying to figure out how to get back to where we were, because we'll never get back to where we were. We really have to concentrate on what areas we can really make a difference with our toxicology knowledge, with our knowledge of human physiology, ergonomics, all that stuff, but to reinvent ourselves, basically.
Thank you very much, Warren. This is excellent. Katerina, what are your thoughts with regards to the psychology at work is really evolving right now as one of the principal things people are talking about? What are your thoughts and how can that help us? Or do you think it's going to help us, and how can it help us?
Yeah, definitely. I think it's definitely going to help us, especially in the workforce. When I was with the city of New York, I managed a unit. I was the health and environmental advisor to the mayor's office, and I did manage a unit. And all the workers were like, I do not want to be here. I need a substance for me to get through the day. Of course, I had to refer them to the employee health program, which really changed their life around, which is great. But who else is going to look at workers? That's what we do now, right? We work. So the occupational medicine physician is going to take care of that. I'm not in the field just yet. I'm taking step 3 of the USMLE, so I'm still taking boards right now. But I see where the future is, and the future could be very bright for occupational medicine. I think, as Dr. Silverman said, we need a makeover. We have to make it really sexy, just like all the other specialties, because it is the original medical specialty. Back in ancient Greece, Hippocrates was looking at soldiers' wounds and cobblers and people who were transporting things. Those were the people who were experiencing wounds and had all these issues. It is literally the original medical specialty, and we should revere it more. The cardiologist can only do so much. And it's the only medical specialty that can look at different problems. There's not a problem that it can't handle, to be honest. It is going to look at the MSK issue and the cardio issue. When you go to a specialist, they would tell you that this is out of my scope. They will admit it to you, but not the doc. The OM doc is going to take it on and see what they can do. So that's what I have to say. Thank you.
Thank you. Maria, how are you? I don't want to put you on the spot, but I want to hear with the final talk from yourself, because we've got about 10 minutes left in this meeting. What do you see? How can we get to where we want to be, in your opinion? What do you think is going to be something that we need to work at to get where we want to? Which door we need to knock on, and how strongly we need to do? We can't hear you, Maria. Sorry. Okay, go ahead. No, we still can't hear you. Sorry. I know that Mike Schwagert is online. He is the president for Occupational Medicine Society. Sorry, Tunde, go ahead.
Thanks for recognizing me. I think the heads of the societies of occupational medicine in different climes should be made to be alive to their responsibilities that transcends just bringing people together for conferences and other endeavors, to actually moving and deciding how occupational health practices needs to be strengthened in terms of capabilities and ensuring that people are adequately trained, able to be at the helms of affairs, interaction with government officials, using their seat of powers to get to the seat to the right people that can actually enforce this. We need that enforcement. We need government institutions to be alive to that responsibility. The occupational health industry needs to be strengthened, and capacity needs to be improved, and recognition has to be made for specialists that are trained to actually do the job. Okay.
Thank you. It's very good. Dr. Schwagert, do you have something to share with us with regards to how to get to where we want to?
Good morning, or good day, good afternoon, everyone, or good evening, wherever you are. Thanks for making the effort to bring this meeting together. I think the issue that we're all facing, and from what I'm understanding and from what I hear, and what I hear particularly in Canada, the role of occupational medicine physician is under-recognized, under maybe not appreciated. And we're also facing the issue, I think somebody touched on it, with other professionals moving into what's been traditionally our space. It's really a Clayton Christensen Innovator's Dilemma, the book that was published back in 1997, where this is nothing new, where physicians have typically been a highly paid commodity. There's other people that can do the work well enough for an employer to consider whether they need to have a physician to do the work, or can they have an experienced occupational health nurse. So I think we're here preaching to the choir, but as a profession, we have to demonstrate to society our value. I think Julie's is taking a step here to do that. That means putting ourselves out there through position papers or other means to demonstrate clearly that we do have a value. And I think the value is that we're very high level focus, as Julie's would say, systems level focus. We need to articulate to our constituents that this is something we can do. I think there was some leadership from occupational health physicians. The challenge is we're such a small group, it's difficult to gain traction, but we need to leverage our expertise and put ourselves out there. We have to start saying this is an important issue, and whatever that issue is that we're focusing on, we can demonstrate our leadership. It's not enough just to say we're the best in this domain. We have to tell people that and explain that. So I think that's going to be the challenge of us going forward, is how do we get the attention? It's a busy world with the internet, with the social media. Everybody's overwhelmed, and there's a lot of fake news out there. So it's very important that we take positions which are clearly articulated and evidence-based. And I think it's only through doing the work to make that effort that we're going to see a slow change. It won't be a revolution, but it'll be an evolution in terms of people's understanding of what it is we do exactly. So I think we got a lot of work to do, and I know Jalise is taking the lead here to bring this group together. I look forward to seeing how this develops and what we can do collectively. Maybe something as simple as collectively meeting either electronically or through the WhatsApp group will be a way to raise awareness amongst ourselves of what we need to do to move forward.
Thank you very much. Rosa, you want to say something? Thanks, Mike.
Yeah, so no, fully agree for what everybody has said. So I believe what we need to show numbers in the companies I work for. Initially, when you start, you're called the company doctor. They think that we are GPs. It's not that. We all know the value of our specialty. We all know the specifics and insights of this. Unfortunately, that is not recognized by everybody outside our occupational health world. So when I show them numbers, when I evaluate the problems they have occupational health wise, then I show them a value for kind of reduce of sickness absence. I show them the value of reduce of work accidents. I show them the value of all the economics that are involved in that. Then they believe you and trust you. So I think we need to do that. I know we are all doing that with our own client companies. We need to do that is getting outside to show in paper, in numbers of what is the value of our specialty. That's the time that we are going to be heard. And I think that's the time that we need. And also we are a multidisciplinary team, as Mary said. We work with kind of occupational health nurses, health and safety officers, even many HR people are very keen to support us. So I think we need to involve those people to try to get that research or statistics to make our things more credible out there.
Thank you. Joan, I know that you are heading the University of Toronto occupational medicine. Do you have anything to add to our conversation today?
Hi, Julie. Hi, everyone. I was sensitive to the comment that Mike said, we're here preaching to the choir. I think we're all here because we believe in something, but talking to ourselves is not really going to be the answer. I think talking to ourselves is a way to brainstorm what we think we should do beyond this group. So I think action needs to be making arguments, identifying the value of the specialty and raising the profile of the specialty, specifically at the University of Toronto, where we are one of the smallest divisions and not terribly well known within the Division of Medicine, where there are almost 20 other divisions. We're becoming more well known because of our presence in meetings and organizational discussions amongst other specialties. So somehow being present on group discussions that include a breadth of other specialties has been one way I have had some local success in raising awareness. I don't know how to translate that into a larger perspective, but it's certainly something to keep one's eye on in terms of opportunities where awareness can be raised. Those are my initial thoughts. I think the other thing to say is that just patting oneself on the back and saying we're great isn't good enough. There needs to be data, and I think Rosa had mentioned that as well. Data gathering and publishing it, really, it's an argument of economics to some ears that will be listening.
Perfect. That's excellent. We are actually running 1 minute above time. First of all, I want to thank everybody who took the time and attended this first session of Occupational Medicine Unfiltered. To me, this was an extremely important event because I wanted to hear first of all, I wanted to understand where is occupational medicine in different parts of the world. And number two is I wanted to confirm to myself if we were facing similar challenges across the board. I'm hearing, yes, it's the same challenges, maybe different in the way the challenge is impacting individuals, the training and so on. However, I would like to start until the next meeting. I want to start, if everybody is accepting it, a group of what are your thoughts of how to reach and to improve our occupational medicine specialty status? What can we do between now and the next meeting in actually making our concerns into a solvable solution that can help us in the long run? And I know Rome was not built in one day. So I'm looking at the next 5 years. I hope that we'll be able to successfully navigate that and make our specialty into a better position. We are important for the workers' health. We are important for the employers' health. And at the end of the day, we are important for the national economy, international economy. If WHO would have had occupational medicine specialists in their midst while they were handling the pandemic, maybe the outcomes would have been a bit different. I was lucky enough to have worked with companies that wanted me to be their consultant and so on, and the impact on them was different. I thank everybody. I thank, first of all, my co-pilot, Cameron, in helping me make this meeting come true. I want to thank each and every one one of you for all your interest, for your active participation in this. We will use clippets of this and put it on social media. Please spread it around. Please follow hashtag Occupational Medicine Unfiltered. Please, if you wish, indicate that you want to be a part of this WhatsApp group, which is going to be just simply about solutions. Nothing more, nothing less. And thank you very much for attending.
Thank you. Bye, everybody. Nice meeting you.
Same here. Take care. Bye-bye.
Thank you, Prof. Thank you.
Bye-bye. Yeah,
Bye.
thank you.
Thank you.
Bye-bye. Thanks very much.
Take care. Bye-bye.
Bye, Jane.
Bye, Julie. Sorry, I only just joined just to hear you closing.
No worries, man. Next time.